by following these patients with CT scans every 6 weeks as well. I think, again, very important for us to think about not just efficacy, but also thinking about safety and quality of life for our patients. So one thing that I should point out for residual disease, at the back end, not only did they receive the systemic therapy randomizations, but you could also do other standard of care interventions, such as radiation. And in fact, when we talk about radiation, you could have had concurrent radiation with T-DXd, you could have had sequential radiation with T-DXd, you could have had endocrine therapy, and so you could have done what you would have normally done in the residual disease setting. And so because we were doing that, we obviously also looked for ILD pneumonitis or pneumonitis risks by following these patients with CT scans every 6 weeks as well. So there was certainly a signal for a higher rate of radiation pneumonitis that we saw. T-DXd is given for 14 cycles at the back end. We did see a higher rate of ILD, not higher than what we know about T-DXd, so same 12% rate. But when we think about early stage breast cancer, we have DB11, where we've used 4 cycles of T-DXd, where we saw the ILD rates were 4% or 5%. Here, understandably, because we're offering 14 cycles of T-DXd, we saw a slightly higher rate than TB11, but in line with what we've seen with ILD rates with T-DXd overall, so 12%. There were 2 deaths on study, and so that's something to keep an eye on or note of, because we can certainly look for these issues and try and avoid that, obviously, for early stage breast cancer. No other newer signals, if you will. We know about the nausea, we know about the fatigue that we can think about with T-DXd. When we think about 14 cycles, I think we all agree, and we all have faced that with our patients in clinic. When you have TCHP or anthracycline THP, some patients are not able to get the full intended 14-cycle course in the residual disease setting, even with TDM1. And I think that was reflected in DB05 as well, where I think both arms landed up getting not the intended 14 cycles, but similar amount of cycles, because it gets a little challenging for patients to get so much therapy for such a long time, and there are limitations to that strategy. So those were the few safety things that really struck and stayed with me in terms of what I need to do. I have to make sure that imaging is obviously picking up pneumonitis and look at the pneumonitis rates, manage the nausea optimally and better, and then see what more supportive management can we do for our patients at the back end.
Well summarized, and I think your point about monitoring for ILD, even though the ILD rates were consistent or even lower than what we see in the metastatic setting, of course, is very important in the curative setting as well. So those Q6-week scans are important. Let me ask you, when you're counseling a patient, how do you frame the risk-benefit ratio, if you will, when you're offering, or when you will be offering, T-DXd in the residual disease setting?
Yeah, no, I think if I have a patient that I'm seeing in clinic with residual nodal disease, or if I had an inoperable tumor that had received, upfront therapy and has residual disease, I think it's very important for us to highlight the impact that adjuvant therapy can have. And we've had overall survival that we have been able to see with 8 years of follow-up with TDM1. We've known that T-DXd has shown superiority to TDM1 in the metastatic setting, and we're already seeing the IDFS benefit. So it's very, very important for us to tell our patients, yes, I'm sorry, we did not see a pathological complete response, but the good news is we have effective therapies that can have survival implications. So I think it's very important for us to highlight that to our patients. I would certainly do that. I would have to discuss with them what I need to do for monitoring and what kind of side effects to profile, and support them with maximal supportive measures for nausea, for fatigue, and monitoring of pneumonitis. But I think very important for us to offer this in the residual disease setting.